Welcome to Accelerating FHIR Adoption and Improving Scalability. My name is Chiara Matrosino with Kaufman & Associates, and I will be assisting with the logistical support for this Zoom session. To ask questions, click the Q&A button at the bottom of your screen. To verbally ask questions, please use the raise hand function under Reactions, and we will unmute your line during the Q&A portion of the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present. If you need technical assistance during the session, please type the issue into the chat box and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Alex Conter.
Hi, thank you so much, and welcome everybody to today's Tech Forum session titled Accelerating FHIR Adoption and Improving Scalability. As you probably gathered from the title and maybe the description when you registered, we are talking about FHIR today, which is that standard that has seemed to preoccupy a lot of mind space in the health IT space as of late, and holds great potential for really transforming the way that we conduct interoperability and information exchange. So if you'll move to the next slide, please. I'll run through a quick agenda. I'm going to start things off just by providing a little bit of background and some historical context for what we're talking about today, and really set the stage for the conversation to come. I've invited three fantastic subject matter experts and folks who have been involved in health IT and working with FHIR for quite a bit of time now, who will serve as our panelists and will help provide their insight to our panel discussion. Each of the three panelists will have about 15 minutes to say their piece, talk a little bit about their experience in the health IT space and working with FHIR, and then we will move fully into a facilitated, moderated conversation about the future of FHIR and topics associated with FHIR scalability. At any point, we welcome audience members to participate by sending us a question using the Q&A function or continuing dialogue or discussion in the chat box. If you'll please move to the next slide. I wanted to just highlight a couple of key moments in the history of FHIR and help set the stage for where things stand today and where we're going in the future. FHIR got started a little bit before this 2012 HL7 workgroup meeting. There was a group of folks involved in HL7 standards community that were called upon to kind of reimagine the standards landscape. And they put together a proposal for what would become FHIR and presented that first in 2012 at this HL7 workgroup meeting. Around that same time, or not too far later in the future, in 2013, the sort of mysterious group of scientists known as the Jasons, published a relatively influential report called A Robust Health Data Infrastructure, which analyzed the current state of interoperability and exchange in the healthcare system, didn't find it particularly effective, and called for some changes. One important underpinning of those changes is the use or the call for the use of public APIs to facilitate health data exchange and really serve as the cornerstone of that health data infrastructure. Shortly after that, we saw the first official publication by HL7 of FHIR as an HL7 standard. This was the I believe DST1 version, which made it through ballot and officially available for folks to use. Then in 2015, ONC published the 2015 edition final rule, which made updates to ONC's certification program. And that's where we first included certification criteria related to application programming interfaces or APIs. It didn't require the use of FHIR at that time, simply was to provide certain information over an API for certified electronic health record products. And FHIR is certainly an option that developers could choose to implement, but at that time there was no specific FHIR related requirements. Then in 2016, The 21st Century Cures Act was passed by Congress and signed into law by the president. It did a number of things, but specific to our conversation today, or for our purposes today, it did a few very important things in the space of interoperability, including defining and prohibiting what is called information blocking. Folks may be aware of ONC's rule related to information blocking, which we'll talk a little bit about later. We didn't ourselves define the concept of information blocking, nor do our rules prohibit it. Rather, we talk about the exceptions to the definition that was provided by Congress. But in addition to trying to promote the broader accessibility of health information by prohibiting information blocking, the 21st Century Cures Act also defined interoperability and required this notion of the availability of APIs that are made accessible without special effort. And then you'll see on some later slides that really became foundational to the ONC Cures Act final rule, where we first articulated the use of FHIR for the certification program. Then in 2017, FHIR Release 3 was first published by HL7. That's important because it was the first time the standard was published in what was at that time called a standard for trial use form, which meant that it was a little bit more ready for people to start working on and developing and picking up to actually go and implement than it had been before. HL7 has since done away with that nomenclature, but there was a lot of activity in the development, software development space, working with FHIR Release 3, where there hadn't been before. And then I think it not listed here, but I think in 2019, FHIR Release 4 was also published by HL7. And then in 2020, bringing us into the more modern era, ONC published the Cures Act final rule, which again updated our certification program, and for the first time included certification criteria related to the use of FHIR. So you'll see at 170.315 G10, which we typically shorthand to just G10, the standardized API for patient and population services certification criteria included those requirements for certified electronic health record technology to make available an API, a FHIR API, and provide a certain subset of information over that API. So if you move to the next slide, we'll talk a little bit more about the requirements that were included in the Cures Act final rule. So again, for folks who aren't as familiar with FHIR and what it promises and sort of what features it includes, perhaps the most important or noteworthy is this concept of an application programming interface, or an API. I tend to use menu, like a restaurant menu, as my analogy of choice when I try to explain what an API is to family or friends who are not so steeped in this space. But basically, it's a way to standardize what an application or a client can ask of a server to get information back. And it's pretty common in the modern internet these days. Most of the applications that we have on our phones use APIs in some way, shape, or form, whether that's to integrate to your bank account or to facilitate ordering meal delivery or booking an airline ticket or travel. These things all commonly use APIs and allow the application to ask the server for certain sets of information that have been standardized by that server, so that all of the applications essentially know what to ask for and the server knows what to provide. And we wanted to bring that experience, and as others as well, want to bring that same experience to healthcare, so that patients and providers can ask electronic health records for information using a standardized menu of options and receive that information in a standardized format. And then those applications can, and the developers associated with them, can innovate on that, build technology capabilities and services around the data that they're getting back over those APIs. So of course, the 21st Century Cures Act introduced this notion that APIs in healthcare should be accessible without special effort. and the Cures Act final rule certainly takes steps to help prevent some of the business and technical barriers that we've seen in the past related to information sharing, or the prohibition or prevention of information sharing as it was at that time. And most, I think, important for setting the stage is that there was certain deadlines included in the Cures Act final rule that required all certified technology developers to deploy standardized FHIR APIs, including both individual level access and bulk level access to their entire customer bases. And that deadline has passed. So that was December 31st, 2022. And so now we can expect that all certified technology does provide these capabilities, does include these APIs, and makes data accessible, data in the form of what we call the U.S. Core Data for Interoperability, or US CDI, which is represented in the US Core FHIR Implementation Guide. And so now that information is essentially available from the vast majority of electronic health products that are implemented in hospitals, health systems, doctor offices across the country. And then, of course, looking ahead, we indicated that in the future, we're looking to build on top of these APIs, increase functionality, different types of capabilities that will help to facilitate new innovative services and practices that application developers can take advantage of. And that's things like scheduling, subscriptions, being able to hook into clinical decision support services, lots of very neat things that are all in active development in the standard space, have started to see some limited uptake in the actual implementation space, but have growing interest around them. If you could move to the next slide, please. We can talk about sort of broadening the picture beyond just the individual and bulk level APIs available from electronic health records to some of the bigger picture ways to access health information that we started to see crop up in the federal space, particularly driven by CMS and its pair of interoperability rules. So that first interoperability rule, the Interoperability and Patient Access Final Rule, which was published in 2020 at about the exact time that we published the Cures Act Final Rule, define some additional types of APIs that we would expect to start seeing in the marketplace, except these not offered by electronic health record vendors, but some of the participants in the payer community. So certain types of payers that are regulated by CMS would be required to provide certain types of APIs for certain types of information. One of those, is a patient access API. Another one of those is a provider directory API, as well as a formulary API, and then some work to support payer-to-payer data exchange. Now, at the time, the CMS rule didn't specifically choose FHIR implementation guides for all of these use cases. They did that interoperability and patient access final rule did build off of the API requirements from ONC's Cures Act final rule. So therefore, the use of things like the FHIR US Core implementation guide, the Smart App Launch Guide, some of those basic infrastructural pieces that were described in the ONC Cures Act final rule, but really left open some of the other implementation choices with a strong preference or recommendation to certain implementation guides being created by the standards community at the time, particularly those led by the Da Vinci Project, which is a HL7 FHIR accelerator. Then in 2022, CMS released the Advancing Interoperability and Improving Prior Authorization Processes Proposed Rule. That's a mouthful, as many of these federal regulations are, but that really has proposed some updates and changes to the very basic API infrastructure from the patient access final rule to include more specific implementation guides and to also expand the purpose and capabilities of the APIs that are being provided by payer organizations. So for example, creating, and again, this is all proposed, this is not finalized yet, but proposing to create a provider access API so that providers can access the same information from payers and health plans that patients can. Further building on the payer-to-payer data exchange concepts and incorporating the use of FHIR, and then also supporting prior authorization requirements and processes over an API. So we'll see what happens with those proposals. Again, they are not finalized yet, and I believe CMS is in the comment review process currently, as are we at ONC. We are currently working on two rules, HTI 1 and HTI 2, which will also expand FHIR capabilities and build on top of the foundation that we've created with the base FHIR API for individual level and bulk access that you see in the G10 certification requirements. And then finally, many of you are probably also familiar with the Trusted Exchange Framework and Common Agreement, which is the latest attempt to try to bridge across the various health information networks and health sharing ecosystems that exist today by creating some common rules of the road and foundational policies that all of these networks can agree to, as well as standards requirements and technical requirements that implementers can build on top of. We expect the first participants to go live in TEFCA later this year, if not early 2024, and that will not include at initial go live of TEFCA FHIR, but we have plans to include FHIR in TEFCA with what's called facilitated FHIR exchange later in 2024. So stay tuned. There's a lot of active work happening in the federal space. And actually, if you go to the next slide, moving out or zooming out even a little bit more, many of our federal partners have also started to embrace FHIR and build on top of the foundation that ONC and CMS have started to establish. So looking at the left-hand side of the screen, you'll see that HRSA is currently exploring the use of FHIR APIs to facilitate health center reporting. I've covered many of the CMS use cases, including those in the patient access final rule and their proposed rule. CMS itself also provides some APIs to enable beneficiaries, for example, to access information, their Medicare information about themselves. Also the data at the point of care API to support providers access to similar types of information that's held by CMS as part of the Medicare program. And then on the right-hand side, you'll see some of the work that CDC has been doing with its investments in the Helios FHIR Accelerator under HL7 around use cases such as situational awareness reporting, as well as immunization system access using FHIR APIs. So that's all to say that we're at the point now where there's been a lot of activity at the federal level, both regulatory activity and requirements, programmatic activity and requirements that I think has driven a lot of the interest and current adoption of FHIR in the healthcare space. But I think the central thesis of today's panel is that just having these requirements isn't necessarily going to bring us to this point in time where we can expect that a lot of healthcare information exchange interoperability is happening over FHIR. There are still a lot of legacy standards out there that continue doing a lot of the heavy lifting when it comes to moving health data around, whether that's our IHE sort of document-based sharing and continuity CCDA, moving documents around, or V2 messaging, which is still a large, has a large install base and is really responsible for a lot of the internet traffic happening in the healthcare space for things like labs and ordering and registering patients and systems. So we don't expect FHIR to immediately come in and replace all of this work, nor do we expect organizations to sort of immediately pivot and go full FHIR on everything that they're doing. And so the question that I've brought these panelists in to come and talk about is, what comes next? What does the future of FHIR look like? and how do we get to this, large scale use of FHIR ecosystem that we've all sort of envisioned when FHIR first came out and held a lot of promise for really modernizing the way that we move data around in the healthcare space. So with that, I will wrap up. Hopefully the stage is well set, and I'll turn things over to our first panelist, Dr. Stephen Lane from Health Gorilla, to share his thoughts and perspectives and talk a little bit about his experience in this space.
Thank you so much, Alex. Can you hear me okay?
Yes, we can.
Wonderful, great. Well, I really appreciate the chance to be a part of this panel. You've got some quite different perspectives here today, so I think it should lead to a good discussion. Also, I'm impressed that there are over 130 people attending today, only about a dozen of whom are my friends. That means there's a lot of new folks here who are learning more about FHIR and how to implement it, and I think that's incredibly exciting. So a little bit about me. I'm a practicing primary care physician and clinical informaticist. I've been an EHR user for over 35 years. I've worked in the interop space specifically for over 15 years. And therefore have been aware of FHIR and trying to support FHIR over the last 10 years or so of its existence. So really excited to be talking about how to scale this. FHIR is mature. FHIR is ready, as Alex laid out. A tremendous amount of policy work and standards work has been done to lay the foundation that will allow us to now really scale this. So I think FHIR does represent the next generation of interoperability technology, both in terms of the content standard and the transport standard. I've had the pleasure and the honor to serve on the ONC's Health IT Advisory Committee since it was launched over 6 years ago, just in response to the Cures Act when it came out. There, I've had a chance to work a lot with folks who are deep in the FHIR space as we've advanced information blocking, the rules that Alex explained, the US CDI, et cetera. So it's really, again, FHIR came out of Australia. It was developed and nurtured by a lot of very, very smart people. The work with Smart on FHIR, et cetera, the development of a number of commercial tools. But its uptake has been relatively low. I think if you asked the average physician or dentist or public health professional, what they're doing with FHIR, they would say, oh, I haven't been burned lately. I think many people do not know what this is or what it represents, and hopefully we can do that. My work with FHIR in my health system at Sutter Health in Northern California really started pretty early. We were approached to help to support the Da Vinci project when it first came out, which focuses on payer-provider data exchange and developing standards for that, which Anna is going to talk to us about in great detail. I had the honor of serving on the Da Vinci Steering Committee, early on and about 5 years ago, and then actually helped to start the Da Vinci Clinical Advisory Council in 2018. And the hope then was really to get this up and running in my health system, as Anna's been able to do. But that was an uphill battle. It was a real challenge to get a large health system to make the investment, to make the commitment, to have the future focus to implement these tools early. But with some effort, we were able to get engaged at least in responding to FHIR-based queries. I think the whole patient access effort where Apple Health was an early entrant and Common Health and others, really that was the earliest application, at least in my health system. I think a lot of health systems of the use of FHIR, and there was quite a bit of uptake. I think those providers who are providing patient access to data using the FHIR standards have really made a lot of progress. I think it's still very small compared to access via portal products, but it's a substantial proportion of how patients today can access their own data. And we propose, and we are doing everything we can within the policy world to try to advance that, to make patient access to data a key component of the FHIR framework. In the health system, one of the challenges with FHIR is that you're sort of opening up the kimono, and making the data available. You give them the address and you get the query and you respond with the data. So I know that early on there was a lot of concern in the health system and clinician community about releasing too much data. Is this going to conform to minimum necessary? Is this going to meet our goals? And I think the info blocking rules or prohibitions that came with the 21st Century Cures Act have really helped that. There is less of a sense that, we don't want to share all of our data because, of course, there's now laws that say you need to, and those are evolving. But I think that was a concern. And I heard early on of a number of organizations that said they're going to put a middleware layer up, where basically they'll serve up the data that they want to be queryable using a FHIR query, as opposed to letting folks get directly to their data store. And I think that, adds a level of complexity we all want to avoid. So suffice to say that I, as Alex said, I am now the Chief Medical Officer at Health Gorilla, been here a little over a year, and really came to Health Gorilla because it's an organization that is moving forward to support TEFCA Exchange as a candidate QHIN, and was really built on a FHIR platform. So it ends up that all of Health Gorilla's network participants are receiving data via FHIR, even though most of the exchange across the care quality framework and with the various networks is still being done via CCDA documents. But in that sense, very forward-looking and having that technology ready and seeing how that's actually working in use. As was mentioned, there are great plans within TEFCA to move from initial document-based exchange into FHIR, hopefully in the early part of next year, starting with a facilitated FHIR exchange, where the QHINs and the TEFCA framework will handle the directories, the patient discovery, but then there will be point-to-point connections established to facilitate the actual exchange. And because of that, it's definitely a step forward from where we are today and all of the bespoke work that Anna and her organization needed to do to get this set up. But it's definitely a step forward, but it's still going to be technically difficult. It's going to take, larger, probably more mature organizations to be able to implement this. So in order to really get this out broadly, I think the eventual move to brokered FHIR is going to be very helpful. Insofar as participants will be able to work with a QHIN, have their TEFCA connectivity established, and then just have FHIR happen as part of that. So I think that, again, we're on a great path going to facilitated FHIR next year. Hopefully we will move to the brokered FHIR soon thereafter. I think that, again, that will open it up to many more participants. There are so many use cases that FHIR is going to facilitate. I mean, push messaging has been a challenge within our community. I've worked very closely with Direct Trust and the direct secure messaging community, and that has been amazing in terms of being able to push messages between organizations, but the uptake has been incomplete. So FHIR push, FHIR being able to do push messaging within TEFCA is going to be very important. Documents on FHIR, we talked about the fact that the vast majority of exchange today occurs using CCDA documents. That's not going to go away, but we can move the documents over into FHIR and use that as a way to move, discharge summaries, operative notes, even the international patient summary is designed on FHIR, unlike the CCDA framework, and really could be well adapted to that mechanism of exchange. We've talked about Da Vinci and all of the many payer-provider exchange use cases. I mean, the beauty of FHIR here is it allows for selective exchange of data over a very automated and efficient pipeline, which we really don't have today. So much of the exchange that happens is either through the narrow pipe of an X12 or a HL7 connection, or through the exchange of files via secure methods, which are very inefficient. FHIR, as I mentioned, very important in the IAS patient access space, and it will be increasingly so. And then there are many opportunities for us to use bulk FHIR and for support of population health, for reporting, quality measures, and I think we're going to see a lot of that. So again, this is a very exciting area. I bring the clinician's perspective and clinical informatics perspective to this. I think Anna and Jason are going to give us a much deeper understanding of the operational and technical challenges, and I look forward to the discussion. Over to you, Anna.
Thanks so much, Stephen. Really appreciate that. And I 100% support that it is difficult. It's not something that that you could change overnight. It's something that's a dimmer and not a light switch in the culture of how we accept this technology. Implementing this technology, you can just flip the light switch and it works. It's pretty amazing how fast it goes. So today, what I really wanted to share with you is the experience we've had in doing this work, and does it work, and does it produce the results, even though the cultural uptake might be difficult, because it's a behavior change, it's a trust change, but the infrastructure, the technology, the actual getting it done, that has proven almost unimaginably, because when you hear some of the numbers, you're like, are you okay? Is that true? But it's true, and I've seen it with my own eyes. So I wanted to share this journey with you today. So next slide. And ground us in why we even chose to invest in this path. And that is because we have a strategic pillar. Our mission is partnering for healing and a healthier future. It's all about partnering. And under that mission, we have a strategic pillar of pop-based care. And these are some of the things that are happening in the landscape that are kind of giving us a carrot, some carrots, some sticks out there to change our behavior, to implement this infrastructure, and more importantly, to really drive our mission, because what we want is a healthier future. And in order to do that, we know that there is computing power out there. There is data sharing capabilities that are much more sophisticated than what healthcare uses today, and have been delivering data like personal identifiable information, financial information for a very, very long time. And so it's very interesting to be in an industry who hasn't adopted a technology such as this, but is trying to squeeze out as much inefficiencies as we can. This is a huge opportunity for us to do so. But in the market, there are changing things. And so we're being asked to do this too. Healthcare is expensive. We have to reduce the administrative burden. It's also not very joyful for providers who have to click 9 times or 10 times to get one piece of information. We have payment models that are transitioning. We see that accountable care organizations are saving the nation dollars, your taxpayer dollars. And it's really important for us to be able to deliver on more of that promise and do it more at scale. So we have to have the systems, the infrastructure to support achieving those things. We have a market that we're seeing a lot of venture capital being invested in healthcare technology, but healthcare right now seems to be almost a shrinking market in revenue. At least that's what it feels like. It's not, because we continue to need healthcare services and will always, but it's something that putting more tech into there just takes more money out. It's not putting it into the care, it's putting it into the technology. So when we see more investing in capital funds for technologies that come into the market, we want to be prepared to be able to take advantage of those new technologies and do that super efficiently and hopefully help our bottom line. We also have changing policy, as Alex spoke about the journey of FHIR and exchanging data in general. And we also have the capability to compute. The digital age is here. We have an app market in almost every single industry except healthcare. And what I mean by app market is that on your phone, you can download an app in less than a minute and it works, and you can sign in and log in, and you know how much your resting HRV is in 30 days or something. So it's changing, and we're here for it, and we are choosing this journey. So next slide. The title of this slide got wiped out, but what it is value creation. So as you think about being a provider in the marketplace, our goal is to be these things. This is how we create value for our patients, value for our purchasers and our payer partners, and any other partner out there as well. As you think of digital interoperability being a very cornerstone of being able to do all this stuff. If we can't interoperate, we can't treat someone make the best decision at the point of care, because all the data is somewhere else. You can't make the best decision if you don't have most of the information you need to make that decision on. And if you have a payment system that you can only talk about one thing in the doctor's office, because health is more than just one thing. So these are the things we work on being viable in the market as we move forward. This is what value creation looks like to our consumers. And one of those things is digital interoperability. It's a cornerstone of what we're doing. So this is why we've made this investment and why we think it is going to create a healthier future. So next slide. The only thing you need to take away from this is that moving data around in healthcare is complex. There's lots of black spaghetti lines here. And it's supposed to, this is a footprint of how we move data around. It's agnostic of the services and vendors that we use, but it's 100% all the places we have to put a patient identity or claims data or other pieces of information that enable our care providers to get the right resources to the people who need it the most at the right time and make the right decision for that patient, or the best decision we can. That's the art of medicine, right? Having everything we can at our fingertips. And that is what this technology enables. So what the problem we're solving for is this right here. It's complex. We have to pay every time we move data around. We have to pay to map data every time we move it around. There's an extreme administrative burden that's associated with moving data to all the systems that support not only value-based care, but fee-for-service care as well. Next slide. So I set you up with the why. I told you the problem statement that we're solving for. So here's the journey we've been on. In 2018, we joined DaVinci through a sponsorship of one of our payer partners. In 2019, we said, hey, everybody around, I've been at Multicare for, I think, 14 years at the time. And so I knew, I had friends and they were like, I said, do you think this FHIR thing's gonna work? Do you think this could make it easier for value-based, for our ACO reporting and for quality reporting in general? And my colleagues were like, I think so, let's try it. Let's just try it off the side of our desk, see what happens. So we got a team together that essentially met to try out a proof of concept to report quality measures using FHIR through a digital conversation, an automated conversation. And I'm going to show you some results of that initial pilot in a few minutes, but it turned out to be a wonderful thing. And we actually got internal support to continue to investigate, what is this FHIR thing going to do for us? So we thought, all right, well, let's take it to a new use case, which was when you're under a value-based care product, you have an eligibility list. Who are you responsible for under that value-based care product? And can we get that in a FHIR API instead of a flat file or a portal download or an automated ETL package? What can we do here? And we got it in FHIR. And by golly, it was so much easier and so much more accurate. We kept the journey going. So we went into doing some prior authorization work. So this is more focused on the fee-for-service world, but also helps value-based care as well. And we implemented a full FHIR service under the CMS waiver to utilize FHIR to do our prior authorization work. So what happens now is you click a button within our EMR. So inside the support staff workflow, they click a button, it launches an app, just like you would launch an app on your phone. And it pulls data from the EMR specifically for that use case, for that person's procedure, whatever that procedure may be. There are a few things we have to fill out because not all APIs are regulated, but they do have to hand enter a few things. But when we do the test to see what application is better, is the bot better, is the payer platform better, is this FHIR handshake better, is a backend just an X12 conversation better. We did a time study, and I'm going to share the results of that on our prior authorization work, but we're about a year into having this live, which means we get to do our final KPI, which is to figure out if this prior authorization method reduces denials too. But we're looking forward to having that science soon in the future. So that's been our journey. Now I'd love to share with you what we've gotten out of this journey. So next slide, please. So this is med reconciliation. This is the digital quality measure that we put into place, that first proof of concept. Oh no, it's not, sorry. I'm sorry, the titles, they must be in white or something. This is actually eligibility because this is matching rate. So this slide is the matching rate for which we reduce the error. So every time you saw a line on that spaghetti diagram that we showed in the beginning is a place that we have to do patient matching. And when we put the API in place, we were able to decrease our error rate by 60%. So being able to do that means that I free up somebody else's time to do patient matching for the more complex, like twins or long, complicated names. We were able to match 95 to 98% of people that first time through, instead of the standard rate that you see in the industry, which is somewhere between 70 and 85%, depending on what your workflow is. So we reduced our patient matching burden by about 15, 16% in total errors. And we're able to free up 5 to 10 minutes per error. And that saved about a FTE a week. So it was, 1 day of an FTE a week, but that was one eligibility file. We do 28 eligibility files. So when I multiply that savings and that burden by the 28 that we're now going to bring in through the same methodology. Oh, and hey, I don't have to redevelop that methodology. I just have to release different keys to bring it through, give different permissions to bring it through. I'm able to reproduce this and then scale that ROI I'm seeing just on patient matching, which is a huge win for us. So this is the patient matching results. Next slide, I think, is the quality results. Yes. So the quality measure we chose was med reconciliation post-discharge. And what we ended up doing was harvesting data actually from the back end. So not direct from US CDI core, because that wasn't available to us at the time. But we from the back end, pulled data in order to serve it up in the API using the Da Vinci implementation guide called Data Exchange for Quality Measures, so DEQM. The DEQM methodology enabled us to improve our performance, so harvest data in a more efficient, effective way by 175%. In that bucket of things, that was 48 extra gaps we were able to close. Those 48 extra gaps actually have a dollar associated with them because we're in a value-based arrangement where we're paid for quality performance. And that quality performance, I'll talk in a minute too on what that produced for us. But what that resulted in was that every time somebody had to do a chart chase for MedRec in particular, because chart chases vary per quality measure, it was $50 per chart, either on the payer side or the patient side. And so we reduced 48 gaps of chart chasing. We improved our performance, which then resulted in a quality performance payment. I think it was a small amount. I think it was, I want to say somewhere around 17,000 or 15,000. No, it was $17,000. And because of that, it cost me, we were like, all right, so we put all this tech in place. How much did it cost us to build that, code it, project management time, et cetera? We dialed in all the numbers, and it turns out it cost us $15,000 to do that. But I got $17,000 back in return. So in year one of that quality performance measure, I'm already showing a return for my patients and my providers in putting this technology in place. The technology pays for itself, which is pretty powerful. That's sometimes rare. But we were really excited to see this result, and you can see why that proof of concept really got us the momentum to continue to invest in this technology. All right, next slide. So this is the results of the prior authorization, and these still stand today. We just did a recent new time study that compared other modalities like payer platforms, bots that are hard coded to go out to scrape the portals that are out there. There's some back-end X12 methodologies you can use to get data and information sent across. And then there's the regular portal. So we compared all 5 of these capabilities, and we did a time study of several different people doing each one a methodology over an hour. And what we found, and this still stands true, so at 3 months into it, we did a time study, we got these results, that it increased our productivity by 140 to 233%. And today we still see that this is 100% the most effective and efficient way to deliver a prior auth. In fact, out of all those methodologies, it's 50% faster than all those other methodologies in place. So using open standards, using the Da Vinci implementation guides to be able to enable this shared operation between payer and provider has immensely given joy back to those people who have to click the buttons and put the information in place. It's helping us secure our data more. It's really giving minimum necessary information to our payers, building more trust with our patients that we're not sending PDFs of their medical records somewhere. It is immensely valuable to our organization, and we will continue to bring other payers along in implementing the prior authorization standard. So we will continue our journey. This is everything that we've experienced thus far. I'm really hopeful that we continue to scale this capability. I think what this open standard does for healthcare is it does give us that ability to implement something in 2 hours. I was on my 3rd call. It happened last week around, okay, we have to download this app that uses the APIs, the USCDA core APIs. And they're like, how long do you think it's going to take to implement this and get this app going? And they go, 2 hours. And I have to blink because it used to be 9 months, a year. And they're like 2 hours. And it just makes me laugh because I am just so joyful in where this has brought us. And I cannot wait to see what the future holds in the app market that we're going to see in healthcare, and the capabilities and the joy that we're going to bring back to people's lives and jobs. All right. I'm going to hand it off to my dear friend and colleague in this marketplace after my last slide, which is, this is the network. This is the network that we're building upon. We have to make this change. think of all the innovations that came out of electricity. This is the US electrical grid. This open standard API and the API services is really the electrical grid of healthcare and is going to be. And I hope that you all are excited and want to come along this journey. And my doors are always open. Ping me on LinkedIn or pick up my email address. I'm happy to answer any questions or help you along your journey because we want everyone to do this. This levels us all up and it really levels us up for our patients. So I'm going to pass it off to Jason for sharing his journey.
Awesome. Thank you, Anna. I guess I saw a lot of friends on the attendee list as I was reading through it earlier. So it's great to see some friends. And as I think Dr. Lane said, some new people as well. So for those who don't know me, I'm Jason Vogt. I work for Meditech as the manager in development. I am also our product owner of our APIs and structured documents for our interop team. Very active in the FHIR space and help facilitate that. I also am the Commonwealth Technical Committee Chair, where I help either chair or have talked often, much to some people's chagrin, in both the FHIR and the TEFCA work groups as part of that. Also a key contributor, or at least I'll call myself a key contributor to both Commonwealth and the Care Quality FHIR API implementation guides, which are both where Commonwealth is being released shortly. Care Quality has already been released, and then an active participant in the TEFCA FHIR roadmap and the expectations of the QHINs in that roadmap. I also worked very closely in the, I guess, in FAST, before it was a FHIR accelerator. I sat on a lot of SME or subject matter expert sessions with that team. And one of the key contributions I feel like I helped with is the Security for Scalable Registration, Authentication, and Authorization Implementation Guide, also known as the UDAP Guide, is what I think we all call it shorthand, which really helped try to bring how to bring the initial scale of FHIR to the network, especially through the ability to create clients. I'll talk about that a little bit more here. And then the key accelerators that I'm in, or I actively participate in, is Argonaut. Meditech was a founding member of the Argonaut as the first FHIR accelerator. And then we have branched out into both FAST for the network capabilities there, and then for Da Vinci, primarily around kind of, as Anna showed just recently, the burden reduction, prior authorization workflows, which we're hoping to release here in 2024. And then an active member in the HL7 cross-group projects work group, really focusing on US core and all of the variance requests and the new US CDI elements that come out every year. So that's my backstory. Where I wanted to start with the journey today was more about global FHIR and like what we do really well today and where we can improve, because obviously there's some things that we're all very happy with, and I should stop looking at the chats, and there's things that we think we can improve. So the first thing I think we do really well today is a lot of point-to-point setup, right? Like as Anna mentioned, right? Like to set up a new endpoint, it's like, okay, what are you looking to do? Okay, I set you up, here's your client ID, here's your secret, here's the endpoint, go make your authorization calls, here's all the scopes I gave you access to, and you can be off the ground very quickly. The hardest part of that whole discussion usually is like, who's the app and what does the app do, which I'll get into a little bit more here on what we don't do well. But we can get those, we can set them up. Some EHRs or some servers have it a little bit better to find the clients, others don't. That's kind of another area that we can continue to improve on. The data quality in the FHIR resources, or like what the FHIR resource looks like and how to profile those, I feel like we have done a very good job. For those looking at the next FHIR versions, right? We have FHIR R5 out there, has a lot of really good fixes in it, a lot of things that needed tweaks that have now been fixed and now can be tested and utilized. And then if you look towards FHIR R6, as Lloyd and Graham and everyone is working on that, like that could be a pretty monumental release, because there is looking at that a lot of the resources that we use today are going to be normative. And that's a big change, because now we're really potentially getting into a release of FHIR that we could stay at for many years, right? Like R4 is going to be around for a while. R6 could double or potentially triple that length of stay at a specific FHIR release if everything trends to that normalized area that they're kind of looking at right now. And that can be a big win, because now we're really looking at like a solidified infrastructure to continue to build off of. And then we can really say, okay, how can we further accelerate that into the future? I think we have a really good handle these days, working with ONC and Argonaut and cross-group projects on how to continually take more US CDI data elements that they throw at us every year, clarify what their intentions are in each one of those, and then profile those. Then we have a really good cadence. We started a little bit earlier this year, had a lot of really good discussions in May at the New Orleans Connectathon and working group meetings for HL7. And then by the time we got to September, we had most of it profiled, and there wasn't a lot of apprehension or discussion. There was a lot of like head nodding, like this all makes sense. Let's continue to push through for balloting. And that cycle has really solidified as we've moved in from 1 to 2 to 3 to now into USCDI version 4. And then it's just the process for publishing IGs as well, right? Like there's many FHIR accelerators, there's many implementation guides, and I think if you start to look at all of them, right, they all have a lot of consistency between them. And one of the main drivers of that is that everything in the US, right, is all based off of US core, all goes through cross-group projects. If you have a discrepancy with US core implementation guide, you have to bring it to the work group and we have to discuss it. We have to figure it out, because we don't want discrepancies. We don't want to like, okay, I implemented US core, but now I can't implement this Da Vinci guide because there's a collision and this one uses a different value set, or this one's required here, but not required here. Those types of issues all have to be addressed so that we have a high consistency value across all of our implementation guides. We have a really good process in place for those variance requests. I know, because I just listened to like 4 of them before this meeting, which all got approved. But so it's working, and I feel like that is something that has really been doing well in the community we have. We're really able to, for those patient accesses that access clients or certain clients that we're talking about, we have a good process for those right now. We have the ability to do the authentication and authorization. The G10, as Alex mentioned, right, has a lot of pieces in there to make sure that we have individually allowed to like determine which data wants to be shared. Do you want to share your observations or not? Do you want to share your conditions, your demographics, all those different pieces? You have the ability to pick and choose which you want to share, and then we can authenticate you against likely your portal credentials so that we know you signed in and you've authenticated who you are and authorized the data to be shared. We're doing well at that from a point-to-point model, but there are some improvements there. As a big proponent of Commonwealth, we've actually brought full document exchange via FHIR to Commonwealth. So if you're on Commonwealth, you may make an XDA request to Commonwealth to go get all the documents, and half of them are probably coming back because they made a call to a FHIR endpoint that returned the document reference resource to say, actually, here's all my documents in FHIR, and then we can convert them back and forth between XDA and FHIR, depending on how the request was made. So at scale, like FHIR is out there at scale in Commonwealth, because we are doing, I don't have the hard number, but it's 40 to 50% of the exchange is happening via FHIR, because pretty much after Meditech, everybody that onboarded into Commonwealth is using the FHIR implementation guides to share, to contribute documents and to consume documents. So there's a lot of FHIR exchange happening in Commonwealth around document exchange. Not necessarily all FHIR resources inside of those documents, obviously, but facilitated through FHIR. One big thing that we've changed between the CDA work group and the FHIR work group for USCDI is we've really pushed very hard this year. Shout out to Gay and Brett and Eric to consolidate the value sets so that the value set you use in FHIR is the same value set you use in CCDA exchange. Are they perfect? No, but they are really, really the same, if not the same, across all of them now, which really makes it a lot easier for us EHRs to do that development work and make sure that they're consistent. And then through the levers that ONC has used, there are a lot of FHIR servers, right? You look at, payers have FHIR servers, all the certified EHR vendors have FHIR servers. Many others have FHIR servers on behalf of those smaller EHR vendors. So there's a lot of FHIR servers out there. So there's a lot of data available. But as I transition now from the what we do well to what do we need improved, the first one I'll bring up is directly related to that. We need more clients, right? The ability right now is for patients to access the data. So patient access apps are available. You probably have one potentially associated with the phone that you use natively, and then there's other ones as well. There's a lot of good ones out there. I'm not going to name any names, but so they're all good. Everyone I've worked with so far has been good. But there's not a lot of EHRs that are clients. There's not a lot of payers that are clients. Payer-to-payer exchange needs to be upped. EHR to EHR exchange via FHIR for treatment needs to be upped, right? We're not utilizing all of the tools that we have available to us yet because the levers pushed patient access, not necessarily EHR to EHR access or provider to provider access, payer to payer. You know, when you start, as I'll steal a quote from Paul Wilder from Commonwealth, like when you start crossing the P's, that's when things to get complicated. Payer to provider, provider to patient, patient to provider, all those P's getting crossed is where, you know, things need to be worked out. And that's one of the things that we need to improve on as we move through our FHIR journey. Overall scalability, right? We talk about fast, FHIR at scale task force, you know, all of that is about trying to scale that. But what does that really mean, right? And the next couple of points here is kind of what that really means, right? Like, okay, we have the ability to do FHIR exchange, but how do we find FHIR endpoints, right? What do we have? Is it a directory? Do we have a directory out there? Do we need to build a directory? Are the QHINs and TEFCA going to have that directory for us? And now I have an endpoint, but what does that endpoint mean, right? We spent in 2022, we spent a good cycle in Argonaut working on what we call endpoint branding or patient app branding, right? So basically, like, not only do I tell you what my endpoint is, but I can tell you what it actually means, right? Like, I can tell you that it's like the acute wing of this specialty hospital is this endpoint versus the acute endpoint. I can put an icon next to it. I can say, actually, this endpoint facilitates these 26 locations that potentially one of them is near you, right? So when you're trying to do a search for a facility, you can find one that's actually near your house because, like, while the major headquarters are maybe in the downtown area, you're way out in the outskirts, and you can find that location out there, and you know, okay, well, that is the endpoint I'm actually looking for because it's associated to the location that I was just seeing last week. Now we have endpoints. That's where the UDAP IG comes in very, very closely here. Is like, now I need a client at that endpoint. I can't go point to point. I can't go and ask Alex and then ask Anna and then ask Steve and say, hey, can I get an endpoint? Can I get a client? Can I get a client? Can I get a client? That's obviously slow. Even if it takes 2 hours, like, you already lost the patient. They're not going to wait 2 hours for you to find an endpoint and get a client ID and all those different things. They want that information now. They want it at the tip of their fingers as soon as they can. The next part is we have patient matching, but what level should that occur at, right? We're starting to look at TEFCA, right? Facilitated exchange. If the QHINs have the patient, if the QHIN can match the patient at their level, what does the endpoint need to do? Does the endpoint need to do a matching, or does it need to just do some verification? Hey, I got your endpoint from the directory. The QHIN gave me the patient match. It says the patient identifier is this. Here's some demographics to go with this ID. Do you have that patient? Oh, I have that ID. Yep, the demographics are verified. You know, here's your, this is the match. Start making the transactions. I have them, right? We also have authentication, right? We authenticate the user, right? But who is the true identity of that user, right? There is a difference, sometimes slight, between the authenticated user and the digital identity of that user. Just because I have a username and password doesn't mean that's technically mine, right? So what kind of assurances do we need in, or what kind of levels of assurances do we need built into this so that a patient can confirm I am who I say I am, so that as a server, I can feel very comforted and safe that I'm giving the data to the right person. You know, so there's a lot of work potentially around digital identity and digital identity sharing in a network that can really help bolster this idea of the patient is who they say they are. The other part of this is I can authenticate at each server, but why do I have to do that 10 times if I been at 10 different locations? I don't want to do that. I want to just sign in, say, yeah, I give this QHIN and everybody in TEFCA the ability to, I want the ability to get all my data. I sign in, I use my digital identity potentially to get in the front door. I click authorize for the network. And instead of signing in at 10 locations, I sign in at 1. It authenticates me, it verifies my identity, and all of a sudden, boom, I have a federated authorization across all of TEFCA, across all of the network, whatever it would like to be. I did it once, and everybody verifies it, and then gives me the data that I'm looking for. And then we talked about more clients. The other thing about the clients right now is like there's not a lot of oversight with clients, right? We have a lot of clients for patient access that are doing the right thing. They're working with Karen, they're getting their certifications, those types of things, so that you can assure that they're in good standing, they do the right things with the patient data and all those other pieces. But there's nothing that forces that, right? And that brings a lot of distrust sometimes into the network if you don't have those different certifications and pieces to kind of enforce that trust. And then lastly, the last thing I'll bring up is like, anybody that knows me well enough, I always have this love-hate with documents and FHIR, but there's got to be some kind of marriage there between them. Is XML the future format of all CCDA documents, or can we have a nice model where document exchange and FHIR work from the same standard, but they can still be shared and contributed in the same way, right? I can still send a direct message, but the payload maybe isn't an XML anymore. Maybe it's a JSON composition resource with all the same amount of information, but now it's one standard that is easily consumable by everybody, that has a little bit better implementation guide and hopefully a little bit more data quality on it as well. And that can help facilitate that exchange in a model that everybody knows and can listen to. So that's kind of my big spiel. As they wanted to say, what was I thinking about FHIR? And these are kind of the thoughts that I had when I was sitting down today and thinking, okay, what do we do well? And like, where can we still improve? Because I'm always looking to improve. And I know like the FHIR community that we've built right now is really strong. And I know that we're going to tackle all these. It's just going to take a little bit of time for some of those pieces because they're a little bit more complex than kind of the point-to-point exchange that we have today. Back to you, Alex.
Awesome. Thank you so much, Jason, and then all of our panelists as well for providing those great intros and outlining some of the work that they were doing with FHIR. We'll move now to the panel discussion portion of our meeting today. I've got some questions I'd like to ask the panelists, and as always, the Q&A box is open. So if you in the audience have things you're thinking about or want answers to, feel free to drop them in the Q&A. We may not be able to get to everything today with the time that we've got left, but we'll do our best to answer as many as we can. So I wanted to just pick up where Jason left off. I think that was a great synopsis of some of the things that we do particularly well today and some of the things that still need some work. I'll also note that at least at ONC, a lot of our certification program requirements and the regulatory activities and policy levers that we pull really focus on the what I call the kind of interoperability layer, right? Which is making standardized APIs available. And I think we've done a good job of that. As you mentioned, Jason, there's a lot of servers out there. But the question I want to ask, and I think starting with Dr. Lane, is what else besides the API, the availability of FHIR servers, what else do organizations need to do to make FHIR work, to really realize this potential of a connected healthcare system, app ecosystem, all of those cool things that FHIR can bring us?
Well, I mean, I'll start in. I think that the key with providers is they are chronically overwhelmed. I mean, they were overwhelmed before the pandemic, they're overwhelmed now. Money is tight, human resources are tight, and attention is really challenged. So I think that the most important thing is really the what's in it for me. And I think that the work that Anna and her colleagues have done is central to that. Being able to demonstrate that this can be done on, a relatively tight budget, that it's not really like other IT projects that, you've sunk billions of dollars into and pissed off your user community, that this has an ROI, even in year one. I mean, give me a break. Nothing does that, right? So, I mean, really emphasizing, and for my part, what, the success of Anna's pilot, the very early pilots of DaVinci work are really, it's important to just shout those from the rooftops and then to see how we can scale those across the TEFCA ecosystem as we move into next year and we start in on that FHIR roadmap in earnest. I think really just bringing people to the table, finding ways to both educate them and even incentivize them. I don't know, we do a lot of work with CMS and CDC and other HHS agencies. How can we use that as a way to kind of pull people in, because we believe that it's the right thing for them to do, but we sort of have to demonstrate it to them.
So if I could quickly follow up on that, Dr. Lane, as a clinician yourself, what sort of messaging would resonate with you when it comes to adopting or using new technologies like FHIR?
Burden reduction. I mean, that's the bottom line. The clinicians don't care that it's FHIR. They don't want to know the technical details. They want you to bring a solution. We want you to bring a solution that will lower the clicks, lower the burden, decrease the time, just the kinds of, and save us money, of course, just the kinds of outcome measures that Anna and her team have been looking at. But I think and frankly, I think prior auth is still a great opportunity. It's one that providers are up in arms about. They're very frustrated. Now, granted, we've got other competing solutions, which are great, gold carding and just decreasing the sheer number of instances where prior auth is being required. But still, when it is required, it's a major pain, right? And it takes time, it takes people, it frustrates everybody. So I think that's a great one. And then other opportunities, within, again, I think that the DaVinci use cases are the right place for us to be focusing our energy. I mean, amazing work has gone into developing those and maturing those. And I think that, prior auth sort of got out in front, but there are plenty of others where you can lower burden, where the provider themselves won't necessarily feel it as much, but obviously their staff and their business ops teams will. I think those that actually get the providers excited should be, prioritized because they help to drive their organizations to focus on these things.
Yeah, absolutely. I think that's definitely a key part. And Anna, I'm sure you have some more to share about working with the providers at your organizations and really drumming up excitement from implementing and using FHIR.
Yeah, so that first use case that we implemented, the med reconciliation one, we submitted it for our internal President's Awards, they're called. And I remember sitting in being in the finalists, and they were talking to us and being like, wait a second, you didn't have to change the workflow to do this? You didn't have to, so many, it's like disbelief, And I'm like, well, here's the money, here's the check, and here's how much it costs. And they are just in disbelief, and also their smiles were like the Grinch at the end when his heart grows 3 sizes bigger or whatever. It was absolutely I mean, talk about filling my personal bucket up. There's nothing better that brings me joy than to make a person's life better, and seeing that in their face when I got to show them what this does, and in their voice. We won that award and mostly because we didn't bother them about it, and we produced the kind of results that help their patient, that help them be providers that give them the capability to practice art instead of this really precise worrying about, did I get all the notes right in there? It's pretty powerful. Engaging them in the prior authorization work, a lot of our clinics, we're a big integrated health system, so we have a staff that's dedicated to scheduling surgeries, or what we have more scale to us in that way. And getting the adoption of prior auth was, I like to describe it as something that goes viral on the internet, because we taught a couple people, and because it was so fast and efficient, and it made their world joyful, and it gave them all the same feelings that that first pilot that had nothing to do with it, you know, they're totally different use cases. It gave them the same joy. We didn't have to teach the organization. The organization just started using it. And that's the kind of human-centered engineering that healthcare deserves, that patients deserve, that community deserves. We want to be a community asset. This is enabling us to do that. This is the infrastructure that enables us to do that. So engaging those providers in that process and really sharing the story has been very important. And being authentic in the story, you know, story sharing, because we're not here to sell you a technology. I'm trying to get joy back in your life. And this is enabling it. It's a small change. It's a different button. Are you willing to click it? And they said yes. And because it sells itself, the technology is just that simple. And it's still disbelief for me. You can hear it in my voice, like, what, 2 hours? Oh, you're joking. Are you joking? So it's very powerful in what we do. And I just hope that we can continue to do it. I hope that we can keep the proprietary models out, and we continue to be creating the electrical grid, not our own proprietary model of sharing data, because the community deserves better health. And the only way we get there is if we have the information to give them better health. And that's through sharing data and information.
Yeah, certainly the on-the-ground impact, I think, of these technologies when they work right is pretty astounding. And I'm sure there's a ton of work that goes into actually making them work right.
There is.
Jason, I wanted to ask or follow up on one of the points you made about the availability of clients. And I think and Dr. Lane, you touched on this as well. There's a lot of attention being paid, especially at the federal level, to this patient access use case. And a lot of the kind of clients that we think that exist out there are sort of the applications that you can get on your smartphone. From like Meditech's perspective or the developer's perspective, how are you going, or what are you doing to fill the gap for provider access, or sort of a killer application for providers to use to make use of these FHIR APIs?
Yeah, I mean, I think unfortunately it's a little slow, but like what we're trying to do, what we've initially done with some of the things is like most of the exchange right now is through the PAMI data, right? Problems, immunizations, allergies, medications, right? So like that's handled, whatever level you want to call it, handled with documents right now for the most part, right? So now we're trying to say, okay, what can we get outside of document exchange for FHIR that can be very, very helpful to everybody? The biggest thing we went for was lab data, right? So like in Canada, we actually work with Healthcare in Canada. As part of that, there is in Ontario, there's a lab network out there. So we said, well, they have a FHIR API. Let's be a FHIR client. So that was our first foray into being a FHIR client, and said, okay, well, it was actually pretty easy. It's the same FHIR stuff that we use on our server. So we basically make the same calls, and instead of asking our FHIR server for it, we ask somebody else's FHIR server for it with a different client ID and secret. And we're able to get all that lab information from the registry and trend it right next to all of our other labs so that they can see all of the different pieces that are there, or the different, all of the blood pressures or all of their glucoses or whatever it is, they can all be trended next to each other. And that implementation is nice because like, can we do it in Ontario for their lab system, or OLIS as it's called? Yeah. But we also turned around and in the Commonwealth and demo with Commonwealth at HIMSS last year, we turned around and hit the Athena server and did the same exact thing. Hey, Athena, give us all your lab results so we can put that in and trend it next to it for our patient and show that in the HIMSS 2023 interoperability showcase, which was super powerful. So now we're looking at how can we expand that, right? Because the one thing that we've done really well, another thing we've done really well is we've given the physician a lot of data, right? Here are 36 documents and 157 resources. Have fun, right? Okay, well, how can we make them actually have fun with that data, right? So what, we talk a lot about AI in many panels, right? I'm not going to say AI is fixing things. What I can say is that I think we can use AI to figure out what data do they actually need, right? Like, hey, I entered this reason for visit. I placed this order. I entered an initial visit problem. Based on those 3 factors, Dr. Lane is looking for some ED visit that has to do with this broken arm that the patient is arriving for, or whatever it could be, right? You pick your use case. And now I can go find that information. All encounters in the last 7 days or 2 weeks, right? Okay, boom. Of those, what are they for? What type are they? Okay, here's the 2 visits potentially that maybe match. Okay, go to labs, go find images, go find other tests, other orders. Okay, hey, Dr. Lane, here's a package of resources I found out in the network that I think can help you make treatment for the patient, have a good treatment experience with the patient that you're seeing. And here's a set of external data that can help. He peruses it, says, okay, well, those labs look good, but I need to go 30 days further. Okay, click, go back 30 more days, runs it, boom, you have your data. And now you're looking at data that is the data you need, that needle in the haystack moment where, like, boom, somebody found me the data I actually care about. All the noise got removed, and I just found that one piece that said, I know how to treat this patient better because I found that data in the right spot at the right time. And AI helped guide me there. And then a few little human interaction and boom, that's there. That takes time, that takes energy to build, but like the ability to query data via FHIR and put those decisions into actions, I think can really benefit everybody by saying, like, I'm looking for these types of labs, I'm looking for these types of encounters, problems, medications, whichever data class you're looking at, like that ability to filter and foster that data to the thing they're looking for, I think is the powerful step that is the next step for us as we figure out how to scale. Now let's find the data in the right places at the right time for those physicians.
Jason, I could not agree with you more. You were very clear on that, but I really just want to emphasize what you said, that over the course of our careers driving interoperability, we went from there's no interoperability to we're never going to get there to drowning in data, and literally, I mean, I'm going to go see patients after this, and I'm going to see a patient that was just in the hospital for 10 days, and it's going to take me the entire visit to just read through those records and figure out what the heck is going on and what the next move is. And the truth is that as we move towards this new world of having too much data or more than we know how to deal with, or the ADT messaging paradigm, where it's like, yeah, someone was in the hospital and, good luck with that, and we need to be able to have these focused queries to get the data that's right, because the data that's right for an oncologist is different than the data that's right for a pediatrician. And, we shouldn't just download all these CCDs and expect the end user to be able to deal with it, because we can't.
It's almost like, me going in there and saying, see my Fitbit heart rate data from the last 4 years, it says my resting heart rate has gone down or whatever it is. We can't take advantage of all this computing power out there without APIs. We won't be able to, because it'll all be in a proprietary data model that we cannot put those new technologies on top of, because they won't be able to map effectively and efficiently and can't do it real time, which is when care happens. I mean, Dr. Lane's in an office, he's got 15 minutes to talk to that patient about their resting heart rate and this one spike, and it's our job as engineers to get him whatever he needs to make a best decision for that patient. And whatever he needs doesn't exist in one software product. It exists in multiple places. And that means we have to have a network of ways to move data around to give him what he needs.
It's really
appreciate all of you.
It's really bringing modern computing tools to healthcare and
Yes.
health data. I mean, that's really what it is.
That's right.
Right. And be able to find those endpoints that he needs, right? Like I think Alex had one slide about FHIR scheduling, right? Like, okay, I need to know where I can schedule, right? And if that endpoint handles 16 locations, like I need to know all 16 of those locations and all the availability at all 16 of those locations. So like all that information through the networks or through however it needs to be somehow made available. And that's where like a lot of the different pieces about like usability really start to come up with FHIR, and like how can we continue to make it more usable and really bring that burden reduction in multiple facets, not just prior auth to the clinician.
We've got a hand up, Alex, from the world out there.
I think Paulo put it.
Yes, I saw we did have, I think it was Paolo had his hand up. Is it possible to unmute Paolo so he can speak up or ask a question?
Yes, I did unmute.
I think he just needs to unmute himself.
Yes.
Paolo, can you unmute? There you go.
Hi. Yeah, I asked the question about, it is about talking about FHIR at scale. So we work on a registry. We try to get lots of data for population health. And right now we have bulk FHIR, or we can check with individual patients one by one. And but bulk FHIR, they still has lots of limitations. Like Epic says no more than 1,000 patients, because or else you just, if you want to ask for 10,000, it will take a long time. And so what, but Medicare wants to move for digital quality measures. And if you're going to do like 1,000 doctors or 100 doctors, it takes a long time to just extract all this data. So what are the things in the future that will allow us to move to digital quality measures and to do this population health at scale?
I can think of a couple, Paulo. Hi, how are you? I hope you'll be at the spring conference, or this one, this one too. I think one of the things that we need is computing power. So right now, our EHRs are on premises. You have to add a physical server to add power to that computer to compute what it needs to do. And that is just a straight up infrastructure limitation that we are going to have to get around. One way we are solving that problem at Multicare is we're putting a layer in between the EMR, because you saw my spaghetti diagram, which you, Paulo, has seen before. Paulo is my friend, you guys. I don't need to get data just to the EHR. I have to get it to multiple places. And so I need a layer that enables me to have basically a postman deliver everything to all the different houses that I need to compute clinical data. And that layer enables me to pull at the 1,000 rate limit and acquire into a space that can enable my endpoint users like CMS to pull a bulk call, because I'm bulking it. So instead of waiting for that infrastructure change right now, because that's going to be a while, we are putting a layer in between that enables us to get around that problem for the time being, but it also serves as an investment for the future, because healthcare data doesn't just live in our EHR. I can't rely on my EHR to be my FHIR service. I need to have my own FHIR service, because I have multiple modalities to deliver clinical data, lab systems, ADT notifications, financial systems. I have payers who need to give me claims when I'm in a value-based care contract. All those things could come through an API, and some of them do, and it is much more efficient. So we have added a layer in between to get around that bulk problem.
Thank you.
Yeah, I guess I kind of threw it in the chat to him, or I don't think maybe ever saw that. But yeah, I mean, as Anna said, like our databases in most of our EHRs are not built off of like huge data modeling databases, right? They're built off of a patient access one at a time model. So to try to say like, give me 1,000 patients of data, we say, okay, hold on, patient 1, patient 2, patient 3, patient 4, on down the line, right? So like, while we can look at, different groups to help, make that smaller, so that like, if you're a payer, you're only getting the patients that you care about because they are, you're their payer, that can be helpful. But like, I think the long-term thing is the infrastructure gain, the cloud database, whatever you want to call that. But that is not a cheap effort for most EHRs. And unfortunately, we have more government regulations coming potentially sometime soon between now and a meeting on the 14th, I would guess. But we don't always have all the time and roadmap space to continually to innovate sometimes while we're trying to keep up with regulations as well. So it can be a thin line or a tight line for a lot of us EHRs as we're trying to both be innovative and keep up with regulations.
Mm-hmm. And Paulo, I'll also add that I've also seen people take, they grab the QRDA file as the foundation, and then they use this US CDI core feeds, the individual CDAC feeds, to create that aggregate bulk feed that would go to the digital quality measure. So I've seen that done too. It's very successful.
Yeah, we get a list of patients like using bulk, a large list, but then we do the query one by one. 100,000 patients for a quality measure can take like 16 hours, but it works.
It works.
Yeah, and I do think that the fact that we're still looking at workarounds to some of these issues, as innovative and creative as they are, speaks to the fact that although there are a lot of FHIR servers out there, we still have a long way to go to make this sort of conceptual ecosystem a real reality. But with that, I do have my eye on the clock. Unfortunately, yes, one of our panelists has to drop, and I think others probably have a lot of stuff going on as well. So thank you, everybody. Thank you, everybody, for attending. Thank you especially to our 3 panelists today. I know in some of our pre-planning calls, they have a lot of information and experience to share. And I think they're all willing and able to make themselves available if you have questions or comments or just want some advice about how to make this stuff work. So thank you so much for joining us today. Thank you to our panelists for sharing their experience with us. I hope to see everybody again coming up soon, especially at ONC's in-person annual meeting. Exciting that will be an in-person meeting for the first time in a long time. So hope to see you there. Again, thank you so much for joining us today and spending your afternoon with us. We appreciate it.
Yes, thank you.
Thanks, Alex.
Take care.